Sorry, ma'am.
Election हो गया?
No. Still people are voting.
Congratulations.
Okay, are we ready, Sunil?
Yeah, live.
Okay. So good evening, postgraduates, and welcome to this 65th episode of All India Postgraduate Teaching Program, an initiative from ARC AIOS. In the last episode, we had two short cases, and in this 65th episode and today's series, we are having the 13 journal clubs since this particular ARC PG teaching program was conceived. And today's journal club would be presented by Dr. Rajeshri Singh, who is a senior resident at Government Medical College and Hospital, Chandigarh, and Dr. Garima Rani, who is a final year resident at RIO, Guwahati, Guwahati Medical College, Guwahati. I'm extremely thankful to the mentors, Dr. Tanu Singh, an assistant professor at Government Medical College and Hospital, Chandigarh, and Dr. Pankaj Barua, associate professor at RIO, Guwahati Medical College and Hospital, Guwahati. Of course, my sincere most thanks goes to the discussant, Dr. Obaid Ruman, who is a consultant at Department of Oculoplasty and Ocular Oncology at Shroff Charitable Eye Hospital, New Delhi. Dr. Anne J.K., who is a consultant oculoplastic surgeon at Little Flower Hospital and Research Institute, Angamali. And our own Dr. Aditi Pujari, who is a consultant oculoplastic surgeon at Sunan Oculoplasty Center and Aadhar Hospital at Kolhapur, for consenting to be discussion. So now, without much ado, can I request our own ARC member from East, who is also an acclaimed oculoplastic surgeon, to carry forward. Dr. Kasturi, ma'am, please.
Thank you, Dr. Prashant, and welcome all of you to this very interesting episode on Journal Club. Two very interesting articles have been selected, and thank you very much for the the speakers today, and also I should say the young mentors and also the young discussants. So we are looking forward to a very, very illuminating session here. So let us go ahead with the first presentation. I think first presentation will be done by Dr. Rajeshri, right? And Dr. Tanu Singh will be mentoring her. Welcome all of you.
Is my screen visible?
Yes.
Okay.
Yes.
Go ahead, Dr. Rajeshri. You can.
Good evening to one and all present. At the outset, I'd just like to say that I'm thrilled and grateful for this opportunity. Today, I'm going to present a research article, which was a controlled clinical study on the efficacy and safety of periocular triamcinolone acetonide injection for treating ocular myasthenia gravis. This article was published in January 2024 in the BMC Ophthalmology Journal, which has an impact factor of 2. To begin with, myasthenia gravis is an autoimmune disease affecting the postsynaptic region of the neuromuscular junction, wherein there occurs simplification of the postsynaptic site with a reduced number of acetylcholine receptors due to the autoantibodies directed against it. The thymus gland is postulated to be involved in the pathogenesis of the disease, and the hallmark of myasthenia gravis is fluctuating muscle weakness. That is, the muscle weakness, it worsens with exertion and it improves with rest. Now, due to the unique organizational structure of the extraocular muscles, they are more susceptible to autoimmune damage. Also, subtle alterations in the function of extraocular muscles are more likely to produce the symptoms. As a result of which, 70% patients of myasthenia gravis first seek medical attention due to their ocular symptoms, and eventually 90% of patients have ocular symptoms. Only 15% of the patients have the disease limited to the eye, and they are categorized as ocular myasthenia gravis. And ptosis is most commonly the first symptom that the patients present with, which can be accompanied with or without diplopia. 50 to 80% of patients with ocular myasthenia gravis convert to secondary generalized myasthenia gravis. However, if the disease is limited to the eye only, for 2 years, patients rarely develop generalized disease. Myasthenia gravis is diagnosed by a combination of ocular examination, pharmacological testing, blood testing, and the electrodiagnostic tests. For the treatment, acetylcholine esterase inhibitors are the first agents of choice due to their rapid onset of action. But because they do not alter the disease process, they are supplemented by the use of immunosuppressants. Plasmapheresis and intravenous immunoglobulins are reserved for acute cases of myasthenic crisis, and thymectomy is also advised in certain cases. However, poor outcomes in elevating ptosis and diplopia, along with the side effects of systemic medications, cause difficulty in the treatment of ocular myasthenia. As ocular myasthenia has local immune pathogenesis, local delivery of drug is a viable treatment option. Past studies have established the role of periocular injection of triamcinolone as an effective treatment for thyroid-associated ophthalmopathy. And because thyroid-associated ophthalmopathy is also caused by inflammation of the extraocular muscles, as is the case with myasthenia gravis, this paved the way for exploring the potential of the use of triamcinolone in myasthenia gravis as well, for which a small-scale study demonstrated the local use of corticosteroids relieved the ocular symptoms in ocular myasthenia gravis patients. The aim of this study is to evaluate the efficacy and side effects of periocular triamcinolone for the treatment of ocular myasthenia and to compare it with the oral pharmacotherapy. The study universe was Wuhan University. The study location was the Department of Ophthalmology and the Department of Neurology at the Wuhan University. It was an experimental study, a controlled clinical trial, which was carried on from July 2018 to July 2022. The study population consisted of two groups. The study group had the ocular myasthenia gravis patients, which were treated in the ophthalmology department, wherein all the patients received periocular triamcinolone injection. Whereas the control group had ocular myasthenia gravis patients from the neurology department that were treated with the traditional oral medications. Now, the patients who had strictly ocular disease were included. They had to had a neostigmine test positive. However, if that was negative, either of the thymus CT scan or the electromyography or the serum should have been tested positive. However, patients who did not support the treatment or who could not complete the follow-up, or with patients who had other diseases which could not support the treatment scheme, they were excluded from the criteria. The ethical considerations were taken well into care. Detailed medical history with general and ocular examination was done, and the required lab investigations were ordered. Specific degree of ptosis and ophthalmoplegia was noted in the study group before and after treatment, but not in the control group. The degree of ptosis was graded from 0 to -4, with 0 being normal, minus being ptosis recognizable with careful observation, -2 being upper eyelid margin covering less than half of cornea, -4 being the patient completely unable to open the eyes, and -3 is anything between -2 and -4. Degree of ophthalmoplegia was graded from 0 to -5, wherein 0 was normal, -5 was complete lack of muscle function, and from -1 to -4, the eye did not reach the midline in 25% of increment. The observed indicators at the last visit was determined based on the Maximum Myasthenia Gravis Foundation of America post-intervention score, wherein the favorable outcomes were either achieving a complete stable remission or a pharmacological remission or a minimal manifestation status, whereas unfavorable outcomes were either just a slight improvement in the status of myasthenia or an unchanged status or worsening or exacerbation or death. This is the manual generated for defining the terms which were mentioned before. Starting with the treatment scheme, for the study group, all the patients of ocular myasthenia, they received weekly periocular injection of 20 milligram triamcinolone, which was injected in the superiotemporal or superior-nasal quadrant. And after 4 weeks, the results were assessed. In case no improvement occurred, or at any time if the condition of the patient worsened, they were transferred to the neurology department and alternative treatment was started. However, if improvement occurred, the weekly injections were continued till the symptoms of ophthalmoplegia resolved, after which from weekly, the patients were shifted to monthly injections for the next 6 months. And then follow-up was done every month after stopping the treatment. For the control group, all the patients in the neurology department, they received oral medication. Patients who had only ptosis were treated with oral pyridostigmine. Patients who had ptosis which were not responding to pyridostigmine, or patients with ptosis and ophthalmoplegia, they were treated with oral pyridostigmine along with prednisolone. But in cases if corticosteroids were contraindicated, tacrolimus was used instead. Follow-up was done weekly. Once stable condition was reached, follow-up was done monthly. And the treatment goals for this treatment was defined as achieving a status of minimal manifestation or better, or a degree of ptosis less than equal to -2, or ptosis not affecting vision at primary gaze, or absence of diplopia at primary gaze. For the statistical methods, the unpaired t-test and the chi-square test were used. Starting with the results, on assessing the basic information of the patients before the treatment, no statistical difference was found between the two groups. However, the two groups were not matched for coexisting morbidities, which could have potentially influenced the response to the treatment. Then, after giving the injections and starting the oral therapy, the treatment response was assessed. It was assessed firstly at 4 weeks and then at 12 weeks. It was found that 86.3% patients of the study group met the treatment goal for ptosis at 4 weeks, compared to only 50% of patients achieving that in the control group. Whereas at 12 weeks, 86.3% of patients continued to maintain the treatment goal, compared to 60.5% patients in the control group achieving the treatment goal. On assessing the treatment goal met for ophthalmoplegia, it was found that 75% of patients in the study group achieved the treatment goal at 4 weeks, compared to 30% of patients achieving the treatment goal in the control group. Whereas 87.5% patients in the study group achieved the treatment goal at 12 weeks, compared to 50% of patients achieving it in the control group, thus proving that the peribulbar injection of triamcinolone alone was better and faster at controlling ocular symptoms than traditional oral drugs. The evaluation was done at the last follow-up also, wherein the rates of achieving complete stable remission, pharmacological remission, minimal manifestation status was assessed, and no significant difference was found between the two groups. Also, the rate of relapse between the two groups was same. Therefore, no difference in the long-term efficacy and complete stable remission rates was noted in the study and the control group. However, the study group had lower rates of secondary generalized myasthenia gravis, but the difference was not statistically significant. On comparing the complications that occurred between the two groups, in the study group, 5 out of 22 patients experienced intraorbital hematoma, which eventually resolved. However, in the control group, 13.1% patient experienced headaches, 60.5% patients experienced significant weight gain, and 10.5% patients experienced abnormal glucose tolerance. The side effects of traditional oral medications have always caused a difficulty in treatment, and complications with periocular injections are not that common. However, local pain and patient fear caused by injection affect patients' long-term adherence to therapy. Analyzing the article, the study question was well defined. The study population comprised of ocular myasthenia gravis patients from July 2018 to July 2022. The follow-up period could have been extended. The inclusion and the exclusion criteria were well defined. For the sample size, 60 patients in total were evaluated, 22 in the study group and 38 in the control group. For the selection of participants, the study group recruited ocular myasthenia gravis patients from the ophthalmology department, whereas the control group recruited patients from the neurology department. For the confounding variables, no statistical difference was found between the baseline characteristics of the two groups. However, the two groups were not matched for comorbidities, potentially influencing the response to therapy. No randomization was done, no masking was done. For the outcomes to be measured, they were appropriately defined. However, they were precisely measured only in the study group. That is, specific degree of ptosis and ophthalmoplegia was measured by the ophthalmologist, but not in the control group, wherein the observers were the neurologists. The observed indicators in the control group were rate of achievement of minimal manifestation status or better, ptosis not affecting vision in primary position, or diplopia not in primary position. Different observers measured the treatment goals in the two groups, potentially influencing the results. The study proved that the peribulbar injection of triamcinolone alone was better and faster in controlling ocular symptoms than traditional oral drugs. However, no difference in the long-term efficacy and complete stable remission was noted between the two groups. And the study group had lower rate of secondary generalized myasthenia gravis. However, the difference was not statistically significant. Interpreting the article, a longer follow period, proper randomization and matching would have established the study as a better level of clinical evidence and would have produced statistically significant results. To end, peribulbar injection of triamcinolone can be effective treatment for the symptoms of ocular myasthenia, as local injection of triamcinolone has the potential to reduce the use of systemic drugs, thereby minimizing the associated side effects. And probably due to better and early symptom control in the ocular myasthenia patients treated with periocular injection, risk of secondary GMG could be reduced. Thank you so much.
Very nice presentation. Like you have done a very exhaustive presentation and very well presented. How did you what was the dose of the oral steroid that was given in the control group?
Ma'am, oral steroid, they initially started with 0.5 to 1 milligram on every alternate day. And then they slowly escalated it till they reached 40 to 60 milligram per day.
Okay, and what was the maximum dose in the case group?
In the case, they all received injections of 20 milligram triamcinolone.
And maximum, how much did any of them have received? Like 20 in every visit weekly, then they made it monthly, right?
Yes.
So what total cumulative maximum dose in the...
Ma'am, they've not mentioned about this.
Okay. Dr. Tanu, would you like to add something?
Yes, ma'am. So I think the major flaw in this article was that the control group, there was not standardized pre and post-treatment evaluation protocol for them. For them, say the indicator of achievement was just ptosis not affecting the vision, as against like an ophthalmology workup where we were evaluating, say, from -4 to going to, 0.2. Again, where the control group showed a significant achievement by going from -3 to -2 in the treatment group. The control group, since it was sort of not exact measurements could be done, the success might have been underrated, because at -2 level of ptosis also, like half of the cornea is getting obscured. So that is going to affect the vision, although the patient might have improved from -3 to -2 or say -4 to -2. So I think that point. Secondly, in the control group, that is the neurology OPD group, the drugs that were given, for how long they were given, that is not mentioned. Also, whether the patient was weaned off from the drug and then they will look for relapse, that has not been mentioned. So again, that adds to the point that if patient was on a certain drug and still the patient relapsed, then that would help us assess that which drug is working and which is not. Thirdly, the rationale behind conducting this study was that they've tried to equate the thyroid-associated orbitopathy with ocular myasthenia gravis. Now, thyroid is essentially an inflammatory sort of a disease and usually affects in and around the eye. But myasthenia has less of inflammation and has more of systemic association as well. So again, that rationale, I don't know how far should be considered like true.
Did they mention tacrolimus and cyclosporine in the control group?
Yes, yes. So they have given tacrolimus only to those patients in which corticosteroids were contraindicated or who could not tolerate the corticosteroids. But then
Dr.
again,
can you highlight how tacrolimus works in myasthenia? Any idea? Just as because you're a resident, that's why I'm asking you this question. Because many times we see tacrolimus is given to myasthenia patient. Do you have any idea how it works? Okay, then leave it. It is basically immunomodulator, right? And it works in modulating the intracellular calcium channels. Okay. So, Dr. Aditi, would you like to add something?
Yes, one more point I just would like to see, starting from maybe basics. Whenever you critically review any article, first thing which somebody who is seeing the article should be very thorough with whatever to avoid any typo errors. There are few typo errors in the articles, which is like something basic, which we need to critically see first. There are some gender this thing which is reversed in few tables. Again, degree of ophthalmoplegia, they have mentioned it like from 0 to -4, but giving results, I think they have missed the minus sign or maybe I did not interpret it correctly. So the minus is missing. Somehow it is, the results are in +3 and those points. So these are something basic things which we need to see while start critically seeing the article. Now coming to like more scientific points, it is very unclear from the data which they have provided, how did they actually decide which case went in the study group and which case went into the control group, or it was just the luck or fate of the patient, whoever landed in neuro OPD went to the control group and whoever landed in the ophthalmo OPD went to the study group. Another thing is, as Dr. Tanu told, there was lack of objective documentation in the neuro group when compared to the ophthal group, because basically the study must have conducted by the ophthal group. Like it looks like it was conducted by the ophthal group. So they documented everything very much objectively. And then because they wanted some control, maybe they went to the neuro OPD and got few cases to just compare it. So the primary people who were studying it were not from neuro. So maybe the objective documentation is lacking in the neuro group. Another thing is, again, long-term study is must, because unlike few autoimmune diseases like IgG4, where it is seen that after 4 to 5 years, the immune response automatically comes down. Myasthenia is not something like that, which will still kind of have the immune response lifelong. So how we are going to just maintain with local injections, and if they are really needed to be repeated after few days, or like a cumulative dose is going to work for long term, that is one thing. Another question or something which I would like to maybe ask Dr. Kasturi and other discussants and other panelists also, that they have given the injection in the superior quadrants, medial and lateral, superolateral, superior, superomedial. So ptosis I can understand, because the drug goes into the superior thing, it will go to the LPS. But in ophthalmoplegia thing, if the inferior rectus or the inferior orbit is much more involved, so do we consider that the diffusion of the drug is going to reach the inferior orbit also and make the muscular movements better? So that is one question, which maybe if somebody has tried intraorbital injection, how it works, like it may be relevant even in TED also. So if somebody has that experience or wants to share that, that will also be helpful.
In TED, basically we inject inferior temporal, and the dose is approximately 24 milligram in TED. 24 milligram to a maximum of we go to 40 milligram. But you're very right, Aditi. Even I was thinking of that question, why only superior quadrants have been addressed and not the inferior? And secondly,
maybe because they wanted to focus on ptosis more
They-
than ophthalmoplegia, maybe that would have been the reason, but yeah.
secondly, they have not mentioned anything like the sample size, how it was calculated, number one. Number two, it was non-randomized study, right?
Correct.
And number two, what is the rationale of doing only a superior injection when we know that all the 6 group, in fact, the 4 plus 2, 6 muscles have been involved in CPO.
Correct.
Sorry, in myasthenia.
Myasthenia.
So, otherwise, but I feel it's an interesting study. Only thing that only complication they have mentioned is hematoma, right? So they have not mentioned any other complication, but we know that local steroid injection can lead to so many other complications. So I think this is one downside of this article. But
Correct.
otherwise, it's an interesting article. I think we should all try and have our own experience, and we can have a more long-term results.
Yeah, absolutely. Like if a patient is demanding something quick result, and maybe till the oral medications take over, or they want to adjust with their dosage and everything, for a quick result, this might be something which will add initially, and then we can maintain it on systemic things if needed. That might be the practical use of this technique, is what I thought after reading the article.
Doctor, and a Yeah.
One thing I was not clear is like they have not mentioned the age group, like which age, I mean, in each group, what was the age group? So some pediatric patients were also there. 13 years was the youngest age. So did it fall in the injection group or systemic group? That also not clear. So whether it was done under local anesthesia, whether it was under general anesthesia, and there are bilateral cases also. So in a pediatric patient giving bilateral injections weekly, when it extrapolate to our population, how to what extent it will be practical, that is also a matter of concern. And the hematoma, as they told, it was a complication. How severe was it? So will it resolve within 1 week? Like weekly injections they are giving. So if it occurred in the first injection, second injection by that time, how was the patient? So that things they should elaborate on that side also, I think. Otherwise, it is a good study to minimize the systemic side effect. Always it is welcome to decrease the dose and duration of the drug. Always expose the patient to less side effects.
Thank you so much. Dr. Ubaid, are you there? Can we have your inputs?
Hi, good evening, ma'am. Yeah,
Good
so
evening.
this is an interesting study and presented very crisply. So yeah, there were some points that I wanted to add. One was that they've mentioned the study period from 2018 to 2022. So most likely this was a retrospective study because there's loss of objectivity at so many places. And an ophthalmologist seeing a patient and neurologist seeing a patient is of course different. Like they've mentioned the grades of ptosis in which they've graded, but ptosis is something that is very well quantifiable by a scale. So it can be quantified into millimeters also instead of grading it as -4, -3, -2, whatever their grading has been. The second thing is in myasthenia, the ptosis is variable. So at what point the patient was seen at what time of the day, what was the patient's condition, a lot of things are going to influence what is the patient's presentation of the ptosis when the patient presents to the clinic. And they've mentioned the study period, but they've not mentioned the follow-up duration. So we don't know what was the longest follow-up because when a patient presents with ocular myasthenia, more than half of these patients are going to convert into generalized myasthenia within 2 years. So keeping this in mind, is a local therapy a good idea, although it is a novel idea? But again, as Dr. Tanu mentioned, the rationale behind comparison of myasthenia and thyroid, I don't know how that is justifiable. The second thing is, what was the follow-up duration, the last patient that was followed up? And the third thing is that as ophthalmologist, when we see ocular myasthenia, were these patients also evaluated by a neurologist separately or a physician to see if the patient actually had generalized myasthenia or not? So I think these are some of the glaring drawbacks, basic drawbacks in the methodology.
Exactly.
And
I
like,
also agree with all
many
your
of the points have been covered. One more interesting point that I wanted to highlight is they mention a fixed dose of steroid, a 20 mg injection of triamcinolone. But when myasthenia presents to you actually in the clinic, patients are going to present with different grades of disease. So some are going to be mild ptosis, some are going to be severe ptosis. So in all kinds of ptosis, is a fixed dose a good idea, or there is some quantifiable measure depending on the degree of ptosis, degree of involvement? All these questions have been unanswered.
Thank you, Ubaid. That was really interesting, and you have really given good inputs. I think we can go to the next presentation. Any more questions? Do anyone of you any questions to either Dr. Tanu or Dr. Rajeshri? Or should we go to the next? Aditi and
No
Yeah,
questions.
no.
Nice presentation, but Dr.
Nice
Rajeshri.
presentation. Nicely summarized everything.
Solutions, methodology, discussion, everything presented very well. I should congratulate both of you, both the mentor and the mentee. Okay, now we have Dr. Rajeshri and Garima. Dr. Garima Rani is from RIO Guwahati. Along with her, we have a mentor who is a very sincere and one of the best mentor. I think, Garima, I am right, Dr. Pankaj Borua, who really takes good care of his students. So very much happy and honored to have both of you with us today. And over to you, Dr. Garima.
Yes, ma'am.
Garima has selected a very interesting topic, and this is a burning issue. And I'm sure lots to hear from all the panelists, and I really want to have a very good discussion on this topic. Go to the first slide. Yeah.
Dr. Garima, you need to unmute. You're muted.
Dr. Garima, you're muted. Can you unmute yourself?
Is my slide visible?
Yes, yes.
Good evening, respected teachers and my colleague. Today, I, Dr. Garima Rani, under the mentorship of Dr. Pankaj Borua sir, I'll be presenting a journal on the topic low-dose bleomycin injections for orbital lymphatic and lymphatic venous malformations. It is a multicentric case series studies, which was published in August 2021 in Ophthalmic Plastic and Reconstructive Surgery with an impact factor of 1.2. As we all know that orbital lymphaticovenous malformations, these are abnormal vascular channels which are lined by endothelial cells, infiltrative lesions, and these are usually infiltrative lesions and they usually contain lymphatic channels and malformed veins of various dimensions. These can be venous dominant or lymphatic dominant. These are benign and rare vascular tumors representing 0.3 to 4% of all the orbital tumors. These are often congenital but these can be seen at any age. Mostly these are unilateral but can also be seen bilaterally, and the clinical presentation, it depends upon the anatomical location. Like deep lesions can cause axial proptosis, compressive optic neuropathy, and ocular misalignment, while superficial lesions, they may cause significant disfigurement. Most of the time, patients present with acute onset swelling due to trauma or after an episode of upper respiratory tract infection. According to International Society for Study of Vascular Anomalies, orbital lymphatic malformations, these are classified as simple vascular malformations type 2A, and lymphatic venous malformation, these are classified as combined lymphatic malformations, which are further classified as macrocystic more than 2 cm, microcystic less than 2 cm, and mixed cystic. Treatment is usually required in cases when there is progressively enlarging lymphangiomas causing proptosis, vision impairment, recurrent episodes of swelling, and cosmetic concern. Usually, patients are benefited from multimodal approach involving both surgical and non-surgical therapeutic modalities. Total excision and obliteration is not always achievable because also there is recurrence and interventions carry a risk of damaging the normal structures. So various sclerosing agents have been used previously, but nowadays bleomycin has been used. Bleomycin has been used and it has come to picture nowadays because of safety profile, easy availability, and its high success rate, and also it has low potential side effects. Bleomycin, actually, it is a chemotherapeutic agent with antimicrobial and anti-angiogenic properties, which was first used in 2012. Its mechanism of action on vascular anomalies because of its sclerosing effect on the endothelium of abnormal vasculature when injected intralesionally. So the aim of the study was to determine the outcome of low-dose bleomycin injections for lymphatic and lymphatic venous malformations of the orbit. It was the study involved 12 pediatric and adult patients which were diagnosed with orbital lymphatic malformations and lymphatic venous malformations. It was carried out between January 2010 to December 2018. The study was conducted at 5 oculoplastic referral centers. First was Sheba, second was Rabin Medical Center, Israel, then Mulago Hospital, Uganda, Sri Shankar Dev Netralaya, Guwahati, India, Clinique Ophthalmique de Tunis, Tunisia. It was a multicentric retrospective case series which was approved by local institutional review board and ethical committee. In this, the data was collected based on the lesion type, location, and results of imaging studies. Also, the previous treatment, comprehensive ophthalmic examination findings were taken, and clinical photographs were also taken, and then whole of the data was analyzed. In 9 of the patients, clinical diagnosis was uncertain, so an initial incisional biopsy was done to confirm the diagnosis. The approach consisted of injecting bleomycin injection, which was diluted with normal saline, 1 international unit per ml. In most of the cases, a dose of 5 international unit of bleomycin was used. For macrocystic lesions, first the cyst was aspirated and then followed by bleomycin injection. But for the microcystic lesions, bleomycin injection was given directly without prior aspiration. In this study, as mentioned, 2 patients from Rabin Medical Center, they underwent injection of macrocystic malformations using contrast material. This procedure was done under digital subtraction angiography using biplane imaging. All the patients, they were examined on day 1, 7th day after 1 month, and 3 months post-operatively or as needed as per clinical examination. If after 3 months any inadequate response was observed, the patients were scheduled for an additional injection. The treatment success was defined as marked improvement in appearance with no associated side effects. Paired sample t-tests were used to calculate the differences in numerical variables pre and post treatment, and chi-square analysis and Fisher exact tests were used to calculate differences in categorical variables. The statistical analysis was carried out using Microsoft Excel 2019 version and SPSS version 25 for Mac. The result, as it was mentioned in the study, 21 patients were recruited from 5 centers. From Sheba, 9 patients were recruited. From Rabin Medical Center, 2 patients. From Uganda, 1 patient. Tunis, 3 patients. And from India, 6 patients were included in the study. The mean age was 17.7 years. Female preponderance was seen in the study. The mean follow-up period was 18 plus minus 15 months. The lesions were classified as either orbital lymphangiomas, malformations, which were seen in 15 patients, and lymphatic venous malformations, which were seen in 6 patients. 5 lesions were predominantly macrocystic and microcystic, while 3 were combined lesions. Also, 1 lesion were located in intraconal space, 1 in extraconal space, and 8 were combined, while 4 lesions were located in anterior orbit, and 7 lesions were present in orbital vicinity. Right side was most commonly involved in the study. The study also included 9 patients which were previously treated with surgical debulking, and also 3 patients out of them had done previous treatment with sclerosing agent. The mean tumor duration was 14.7 years, and the study patients received an average of 2 injections of 5 international unit of bleomycin to a mean dose of 12.4 plus minus 10 international. The large intraconal lesions, they were associated with limitation of ocular motility in 6 patients and decreased optic nerve functions in 3 patients. Also, the larger lesions were associated with signs of ocular exposure in 3 patients and punctate keratopathy in 1 patient. The cohort's visual acuity, it improved from 20 by 64 to 20 by 37 at the end of follow-up, and 20 patients showed marked improvement as judged by clinical examination, photographs, and imaging. 10 patients needed a second procedure due to recurrence or insufficient improvement, and 2 patients required a third procedure. And one of the patient did not improve, reported less ocular discomfort after the treatment, but the patient was scheduled for an additional injection after study closure. These are clinical photographs taken from the journal. This is a 36-year-old female presented after failed sodium morphate injection treatment, showed excellent response after single injection of bleomycin. Then next is a 2-year female with left superior orbital involvement after 2 injections of bleomycin. 9-year-old male with right intraconal lymphatic venous malformation showing near complete resolution after bleomycin injections. 48-year female with right intra and extraconal lymphatic venous malformation after 3 bleomycin injections showing near complete resolution. Usually, the most frequent presenting feature of orbital lymphangiomas are proptosis, ptosis of affected eye, periocular mass, physical disfigurement, restriction of extraocular movements, and compressive optic neuropathy. Surgical procedures, these are usually challenging because of the bleeding potential of the malformations, their infiltrative nature, and the complex orbital anatomy. Also, surgery may be associated with severe ocular morbidity and poor outcome. So, various sclerosing agents has been described like sodium morphate, sodium tetradecyl sulfate, ethanol, doxycycline, but they are less useful and usually associated with high local site infection. In the current study, 2 surgical techniques were used. In the first technique, the bleomycin was injected directly in the lesion, and in the second technique, bleomycin injection was performed using image guidance in few of the patients with lymphatic venous malformation. Both methods are safe and effective. Direct injections, it is usually simpler, and as it does not require highly qualified medical personnel. And also there is an additional advantage that in adults with superficial lesions, GA, general anesthesia may not be needed, as most of the cases done in the study was done under general anesthesia. Possible complication of bleomycin includes transient fever, local infection, local inflammatory response, vomiting and diarrhea. However, no systemic and local complications were encountered in the present study. Gooding and Mayer, they were the first to describe the bleomycin for orbital lymphatic malformations. Their patients were injected every 4 to 8 weeks for a total of 1 to 6 injections, and they all showed significant regression and clinical improvement. Similar study by Raichura et al. In their non-comparative interventional case study of 13 patients showed orbital lymphangiomas showing favorable and promising results with intralesional injections of bleomycin. And another study by Anita T. Mohan concluded that serial intralesional bleomycin injections, these can be effective and also safe in pediatric population. So bleomycin, as it is concluded that bleomycin is safe and effective to cause reduction in clinical manifestation of orbital lymphangiomas. Also, it can be considered as first line of management option. Repeat injections, these can be given after an interval of 4 to 6 weeks, which can lead to progressive reduction of lesions. And also it is a minimally invasive procedure, which obviates the need for major surgical interventions.
So regarding the, this is orbital lymphangioma and lymphovenous malformations. This is a large case series of the 5 centers across the world, 2 from Israel, 1 from Uganda, Tunisia, and India. And so here the inclusion criteria and exclusion criteria are not mentioned. And out of 21 cases, only 1 case is given the percutaneous, and all cases are given under general anesthesia. And in case of lymphovenous malformations, usually we have to go for the image guidance so that there should not be the sclerogen goes inside the cavernous sinus. And regarding the pre-injection and post-injection parameters are not mentioned. And so in some studies, there are injections are repeat injection are given 4 to 6 weeks. Here the 3 months. And another thing is that there is a long geographical distribution. So I want to know from the panelist, is there any changes may occur in the year? And so these are the things. I am costume ma'am is there, ma'am. This is the one of the cases we have tried along with the interventional radiologist from the RIO Guwahati Medical College. This is a bilateral anophthalmos with the lymphangioma of the right eye. We have given 1 dose of bleomycin and waiting for the 2nd dose. So I want to know from the costume ma'am whether we should go for the 2nd dose and 4 weeks, 6 weeks, or from the after 3 months. So
very nice
so
presentation.
please, costume ma'am can highlight.
Pankaj, very nicely discussed. Thank you very much for all the inputs. I think you can stop sharing the slide. Yeah, we can. So this case which you are showing is very interesting. Initially, this is a comparatively old study. I think 2021 it got published, and at that time that was the procedure all was falling, and that happened to be the largest case series. It was basically a study by guys, and then we all collaborated with our cases. Basically retrospective, so there was no definite inclusion or no definite protocol to go ahead, but it was only published with the aim to show the highest number of orbital lymphatic malformation which can be managed with bleomycin. Regarding our case, if you ask me now, I usually assess the patient after the first injection, then I call the patient for a repeat MRI or a CCT after a month. If I see there is very good, he's responding, because many times we see the small children, they respond with a single dose. If it's responding, if the proptosis has decreased and then less than 1/3 of the lesion, that means 2 has been taken, then we wait to go for the 2nd dose. But if we see that it's not responding very well, then after 1 month we go for the 2nd dose. And the 2nd dose, what this study has shown, it was have diluted, because what we get in 1 ml, we get 15 units. So they have taken 1 ml, they have taken 1 unit per ml, which is really a good amount of. I want to even compartmentalization, I want to decrease the volume but increase the dose. So what I do, I give 5 ml in the 15 units, so that 1 ml we have directly 3 units, and maximum. So within 2 ml with a little amount of volume, that is maximum 2 ml of fluid, you can. That is what I am following. And if it is an orbital deep, all these cases I usually go under ultrasound guidance. And especially not only for the, the veno-lymphatic malformation, even for the low flow ATM, even for the orbital varicoses, I think this is really STS, that is sodium tetracycline, and along with yours, very good, and also for your orbital varices. But this is something very interesting. And just because it has come for discussion, I'll tell you how a long time patient.
There is some, Dr. Kasturi, there was some disturbance in the network, I guess. Yeah.
Can you hear me now?
Yeah, it's
Yeah,
better.
now it is
Yeah,
clear.
It's a very interesting study. At that time, what we used to do, we used to except for okay, Picni Sibylla, except for this, the option, and then we do it from Japan. So what I was doing, for some reason, after doing a partial excision, because it was also, I gave him just oral doxycycline. And believe me, I could see the reduction of the mass. It has struck me that time, but now people are also giving doxycycline. That we did not follow up. And if you follow up that time only, we would have realized that even doxycycline has a role, whether it's oral or whether it's intralesional. But I still remember 2-3 of my patients where I have given oral doxycycline and had done a partial, excision. Those patients had also done very good and no recurrence. That is something very interesting. Just I am sharing out of the way. So there are different types of sclerotherapy, but what we all follow is basically your bleomycin, and also sometimes we follow the STS. Aditi, what would you like to add something?
Yes, I think first of all, very nice presentation, Dr. Garima. All the points were nicely covered. Basically, it is a very nice article. Was published in 2021 when actually bleomycin was, we didn't have such a large case series at that time. So it surely added to the evidence that bleomycin surely works. And nowadays, as Dr. Kasturi told, it's something which has become kind of almost like a gold standard for cases which we are very sure that those are veno-lymphatic or lymphatic malformations. So about this study, I would say like all the multi-center studies have their own pros and cons. Pro is like obviously they have a better sample size. So the evidence generated from those studies is always a better one. However, like from going to the negative points, if it is not conducted properly, sometimes there are few variations which occur, especially if the study has been like carried out at different places, different countries or continents, because the practice patterns might be different. Here, most of the things I see were kind of standardized, except for the way how the injection was done, except in one center, rest of the things I think again were similar. Another thing which I would like to maybe ask Dr. Kasturi or discuss, because she was a part of the study, why 5 international units was chosen? Was there any specific reason why that was the base cell dose? Because the size of the lesions might be variable. There might have been few smaller, few bigger lesions. So any specific reason why that thing was chosen? Because if it is really like macrocystic kind of thing, we have a bigger cavity where we need to actually sclerose whole of the wall, whereas microcystic disease, in my opinion, might do well with smaller aliquots of things, bleomycin in different quadrants or different regions of the thing. So was there anything like related to that? That was one. Otherwise, like it is a very good study. Yeah.
It was not exactly like that, because at that time when the macrocysts were there, there was some amount. After expiration, it was being injected. So 5 in that sense, 1 ml was added to like 15 ml for 15 international units. So 5 ml was quite a 5 international unit was quite a big volume. So to
Correct.
prevent compartmentalization, a maximum of 5 ml. So that is what I have mentioned. But now what we do, we have a more concentrated dose so that we prevent all this compartmentalization.
Yeah, exactly. I was just going to add that when we have a slightly maybe see when the initial use of bleomycin was used mainly for head neck region where they have a bigger cavities, bigger lesions, so they need bigger volume of the drug to cover whole of the cavity. Whereas in orbit we have a lesser volume, and as we know, even bleomycin will cause a lot of inflammation. But the inflammation is going to be the positive thing for us because it is going to cause sclerosis. So we cannot give more of anti-inflammatory or steroid kind of thing. Otherwise, it will just negate the effect. So to avoid any compartment syndrome like thing, we need to give the volume thing needs to come down. So maybe we need to give a more concentrated dose of the drug with less volume. So what I do generally is I tend of like I decide the dose which I need to give, like not a very objective criteria though, which I have, but then depending on the size of the lesion, I kind of adjust how much of dilution of that drug I'm going to do. So is that the same thing which Dr. Kasturi or other discussants do? Like, I just want to know that. Yeah.
Exactly. Like when it is more in the face and the neck, like how that OK432, the pisinibel. The pisinibel, when it was first started, we have seen a huge amount was given because it was in the place where there were good lymphatics. But in orbits, we do not have good lymphatics. It cannot be drained out. So anything more volume leads to compartmentalization. So we need less volume, but with a good concentration.
Correct.
So that is how we decide. But if it had been face and neck, I think it is not much of an issue, even if you go for a good amount of volume.
Correct. Correct. I agree.
Ma'am, I want to ask one thing. Ma'am, there is a 4:1 ratio of lignocaine and bleomycin is usually when it is given the per cutaneous or per conjunctival. And another thing is that if it is a lymphovenous, then if there is a chance of channelization to the cavernous sinus, so somewhere it is written that the cyanoacrylate blue is used to prevent this percolation to the cavernous sinus. Is there any how it is given the cyanoacrylate use?
Initially, when people started, they used to do under fluoroscopic control, right? Even Dr. Bipasha from SNG has a very nice publication where ultrasound guided. So anything deep, we also do ultrasound guided, and that is one of the best practice management. If you can do under imaging, if it can be done. But we use cyanoacrylate when we plan to excise, because the moment you inject cyanoacrylate, it solidifies. Only on surgery, during surgery, but best is if it can be done in the fluoroscopic, imaging, but which is not possible in our part of the country. But I have seen many of my friends, like Dr. Hunter from Hong Kong. He has got a huge series of all the vascular tumors that he has been managing, and all they do under fluoroscopic guidance.
Yeah, even in my practice, I generally do all these injections like USG guided injections because I feel safer, especially when maybe superficial things I may not bother much when they're like periocular rather than orbital. But for orbital, surely USG gives us more confidence of injecting the drug. And we are very sure that we are actually aspirating the correct thing and because unless we aspirate the fluid in case of macrocystic things, unless you aspirate it, our drug is going to get diluted and it may not reach the wall. So it is very important to actually enter the cavity in case of macrocysts. And obviously the safety part of it surely increases when you do a USG guided thing for orbital.
Interesting, yeah, interesting. Many people, they use that 5% sodium morphurate, which was also used in this study. 2 of the patients, I think, already had sclerotherapy with sodium morphurate. But I feel that amongst all the sclerotherapy, what actually works is definitely bleomycin and also sodium tetradecyl sulfate. This also has a better role. Any experience by any one of you with the sodium morphurate? Aditi, you or Anyone else? I can't see.
Most
Because
of
I
the time,
think
like
in some
sodium
Indian
tetradecyl
centers they
sulfate,
are using.
sodium tetradecyl sulfate, I'm more comfortable in. Maybe I commonly use it for the cystic eyeball, like anophthalmic socket with cystic eyeball. Somehow I haven't used it in like venolymphatic malformations where there is a seeing eye and all. I don't know what exact reservations I have, but that is how I have been doing it. So I feel more safe with bleomycin. Maybe STS has a lot of inflammatory component when compared to bleomycin, which may cause a compressive optic neuropathy, which we obviously don't want.
One question I wanted to ask Dr. Kasturi is, when you aspirate a macrocyst, do you calculate the volume and then give the injection? Is it necessary like that? How much you are aspirating and
So, like in the textbook, it is mentioned that how much you aspirate, and on the basis of the aspiration, you
supposed to
inject.
give only 3/4 of the aspirated volume.
If you can aspirate, especially when there's a chocolate cyst and you can have a good amount of volume aspiration, then it is better to calculate. But many times we don't get so high amount of aspirate.
Yes.
So for me, on the table, I go maximum, if it is adult, to 9 international unit, and for children, maximum 6. That is what I have been following. And this has really been a wonder drug. Like for the children, even with one dose, sometimes it really dissolves everything. But in adults, you do need repetition at least 3 or 4 times.
And one more question, do we have to wait really 3 months before deciding about the second injection? Or can we give it?
No, if you think that it is responding very well, where more than 2/3 of the lesion has vanished, then you can wait. But if you think that it has not, but slight chota amount, like small amount has resolved, then you can go for the second dose. After the third dose, maximum will resolve, provided it is really a venolymphatic malformation. Many times even low flow AVM are also misdiagnosed. That is what I have seen. So it is very important that a very correct diagnosis should be done.
And this study you have mentioned the range of injection is 1 to 6. So I thought it was maximum of 6 injections, but in the literature it is mentioned only up to the third injection. So can you clear?
There are some literature who says you can go up to 50 international units.
No, I am talking about this article which is present.
That was in the initial phase. Now, like that was something very excited, and we were very excited when we saw that when all these 5 centers collaborated, the number was really high. The only objective at that time was that the highest number, how it was being managed.
Ma'am, after post-injection, what is the standard regime? Is there any oral steroid or oral inflammatory antibiotics?
Sometimes in adults I mentioned, I give oral doxycycline. Just because the way it responds in the children, that response you may not see in adults. So I want to add some amount of doxy, because I also know that doxy has some amount of effect on the endothelial lining of the cells or the channels. So on that basis I add, and that is only for the children. We don't add anything. This antibiotic I drop for 1-2 days, 3 times per day.
What I feel is if we are actually giving kind of steroids or NSAID, we are actually negating the bleomycin. So
exactly.
The edema or inflammation, whatever is happening, it is actually the reason which we want. So we should ideally avoid giving steroids or anti-inflammatory post-injection. So unless you are like seeing exuberant edema or compartment-like syndrome where you are afraid that the vision is going to get compromised, then might as well, that is the only time I would like to give steroids. Otherwise, I would like to avoid steroids post bleomycin injection.
Any role of brain?
We asked me, I must have done more than 50, 60 or nearly 70 such patients. I think a very good documentation. I have only one patient had compartmentalization. That is long time back in the initial days. So, but much amount was also not given to him. He was, someone had operated him outside. It was a surgical case, which was diagnosed as lymphangioma. So when he came back to us and I have given him bleomycin, I gave him approximately 3 ml. But he developed compartmentalization and immediately I had to do cantotomy cantolysis. That is the patient I gave IVMP. And after 1 dose of IVMP and followed by little steroid, he was doing good. So and later, after a few months, he had a lesion here in the temporal region also. There also I gave bleomycin. But at least for the last 10 years or more, I think, or more, there's no recurrence.
In cases where the patient presents with acute proptosis and RAPD, is there any role of pre-injection IVMP, ma'am? Like just to relieve the pressure or something like that?
Usually, when you say that when is a bleeding within the presenting with
It's 9 o'clock.
You mean that when there is a chocolates or something compressing the optic nerve?
Yeah,
right?
patient present with acute inflammation
That
also.
is inflammation. Like that is not something inflammation like TED. We need to decrease the inflammation. No? Here we need to decrease the compression. So you have to
directly give.
You have to aspirate.
Yeah,
Aspirate.
even I agree. We need to decrease the volume rather than
Get an
decreasing
imaging
the
and
volume
aspirate.
first.
No need. Okay.
Ved, you're very silent. Would you like to add something, Dr. Ubed? Oh, he must be operating. Can you hear us? Singing.
All of on the way from all the points have been covered well, ma'am.
Chalo, I think with this will not, because today's Durga Puja out here also, I'm sure Pankaj and
Dr.
Garima
Kasturi,
will
just
be taking.
before you finish, I would just like to add one point, especially for bleomycin. Even though it is proved that bleomycin works wonders, but if whenever in doubt, always do incision biopsy, confirm that it is venolymphatic, and then go for bleomycin. Because I had 1 or 2 cases which were classical presentation like venolymphatic. So I thought of doing it, but for some documentation purpose, I had to do the incision biopsy, and then it turned out to be something different. So whenever, maybe if I would have directly gone for bleomycin in those cases. So after that, I have kind of most of the cases, unless they're very classical with sudden proptosis and everything, I would still like to go ahead with incision biopsy, confirm, and then only go with bleomycin. Because bleomycin is something where we are not going to get evidence histopathologically of the disease. We are kind of assuming that it is a venolymphatic. So that is one thing I would like to tell all the PGs or people who are not doing this thing commonly. Yeah, that was just one point I wanted to add before we end. Thank you so much.
With this, we conclude, and we should have a picture together, right? Ubed, can you show us your face, Rajeshri? Can we have a picture, all of us? Yes. Can we see you also, Dr. Ubed? Yes.
Yeah. Yes,
Can we see that? Anyone taking a screenshot? Let me see. Yeah. So thank you all. It was really wonderful, and it's always a learning from both the ends by both the mentors and mentees. And when the more we hear, the more we discuss, the more we learn. And thank you very much for joining all of us for AIS ARC program and
Thank you so much. Thank you so much. Good night.
Thank you so much, Dr. Kasturi and Dr. Prashant, for making us a part. It was really interesting.
Thank you.
Yeah, really very
Thank
nice.
you.
And both of you presented very well. So God bless all of you and happy Durga Puja to each one of you. Thank you very much.
Thank you.
Thank you so much.